Yep.
Okay. We have a lot of good questions tonight, and I'm going to ask for volunteers of the three of you to answer each one of them as they come along. And the first one fits in very nicely over here. Double knee replacements. Do they do each knee separately or both at one time? How long is the hospital stay after that surgery as opposed to what you said before? What do you guys want to think?
Yeah, I can take that. That's a great question.
Selfie.
Selfie?
Everything's selfie.
All right, so that's a great question. In terms of doing both knees at the same time, that's definitely a possibility. I tell patients that as long as you don't have any cardiac history or lung problems or any other major medical problems, that's fine. And if patients do want to undergo double knee surgery, then we do it under the same anesthesia, during the same hospital stay. It is double the operative time, double the blood loss, and it hurts twice as much. But we do it, and it can be done successfully as long as you don't have any major cardiac or pulmonary problems, and your internist gives you the clearance.
Super. I want to make a couple of comments myself. First of all, Dr. Quach showed something that we try to get to you guys all the time with each of these sessions. He talked about evidence, A, evidence, which means the evidence in these studies is really good. B, it's fair. C, it's not particularly good. These are things that are done through the guidelines that we mentioned when I spoke briefly at our first session this year. If you want to look up guidelines, you can look up guidelines from any medical thing as they exist online and discover what the guidelines are for treating heart failure, what the guidelines are for orthopedic surgery, what the guidelines are for different kinds of medications and so on. And I recommend that when you have any kind of problem with your physician or with any particular problem, try to look up these guidelines. It's really not hard. Okay, next question. Does Medicare pick up most of the bill? The reality is that Medicare will pick up most of the bill. Certainly for the surgery, everybody has a basic bill for the first time you go to a hospital. There are copays that a 20% copay that has to be paid usually through your secondary insurance. In terms of rehab, maybe Linda can help me. I don't know how many. Dannick can help me.
I do this all day long. Unfortunately, the business side of it. Medicare for the rehab will pick up for the first 20 days that you're in a rehab center, will pick up 100% of your stay. If you stay beyond 20 days, they will pick up 80%, there'll be a 20% copay. If you have a co-insurance, they may pick up the copay. What will determine the length of stay, the Medicare guidelines will pay as long as you require what they call the skilled services. So that means that you require the nursing care, you require the assistance of a CNA to do your activities of daily living, and you require the intensive therapy. So the typical guidelines we use is once you can get out in and out of your bed by yourself, that you can walk about 100 feet, which is what typical household ambulation, and then you take yourself to the bathroom. That's usually when we'll try to get you home so you can continue therapy either as an outpatient or home care.
Thank you. One more aside over here. Quach mentioned some of the aids we use, like canes and so on. If you see an elderly woman walking with her shopping cart and she's not near a supermarket, she's using that instead of a walker or a cane because she's embarrassed to use a cane or a walker. Shopping carts are pretty useful as walkers. I'm less embarrassing. Okay. Next question is a question that I was left this morning. I had bilateral knee replacement done in 2005, 9 years ago. They are supposed to last about 10 to 15 years. I was told if I need them to be redone, the new ones would not be as good and decrease my mobility. Is today's surgical technology better than what was available in 2005? And would the new knee replacements be just as good, if not better?
So, like most things in medicine, we can't give you a specific answer for in terms of how long these will last. It's usually based on a range. And the range is based on testing that we do in the lab, because like Dr. Derasari said, the part that wears away is that plastic insert that's in between the two metal pieces. And how fast that wears away depends on a couple of factors, right? Depends on obviously your weight, depends on your activity level, and what you do to that knee, all right? So although, you know, that particular question focused in on 10 to 15 years, it's not like a clockwork where at 10 years, it's like, okay, it's time to get changed, like an oil change, where after 5,000 miles, you gotta come in for a checkup. You know, we go based on symptoms, based on people's problems. We look at x-rays to see, you know, where and how the knee is worn away. That's part one. Part two of that question talked about, will my second knee not be as good? That's hard to say. The second surgery is obviously a little harder because the first surgery, we took away the bad arthritis, we put in a new knee replacement. The second surgery, depending on how bad the bone is worn away, how bad the plastic is worn away, and whether you need to actually change the actual components. If all you need to do is change the plastic, then it's not a bad surgery. If you have to change the metal components too, then it's a little more technically difficult because you lose more bone. And every time you lose more bone, the surgery becomes a little more technically difficult, because then it becomes harder to, the whole purpose of the surgery is to recreate the knee, right? You take away what you need to take away, and you replace it with a different material, in this case metal. As you take away more bone, it becomes more difficult to make it perfect in terms of the geometry, the symmetry, and the anatomy. So that's part two. Part three, the technology these days is better, and it's better in many ways. First, the plastic that we make these days, because of the way we process it, we think lasts longer. In the lab, it's been shown to last longer, but we haven't used it long enough in humans to say for sure it lasts longer in humans. But in the lab, when we test it through cycles of, you know, wear, the wear rates are definitely much lower. The second way the technology has improved is in the way we do the actual knee replacements. There are many new sort of up-and-coming technologies where we can get, you know, send patients for MRIs, get blocks of their knee to try to, you know, again, the whole goal is to recreate anatomy. So we can actually get blocks of their knees made so that maybe we can get a better picture, a better sense of the anatomy so we can recreate it better. There are robots now where we can use to, again, help us in trying to recreate the anatomy, as well as, you know, other type of devices that can help that. So one, the plastic is better, and two, the technology to do the knee replacement is better. So the answer is yes, and obviously in medicine and in life, we always try to achieve to try to do better. So as long as there's progress, there's always going to be better and newer techniques.
Thank you, sir. Next question has to do with, it's really a multiple question.
Watch your feet.
You're wrapped in the wire.
Okay. The next question has to do with a new kind of thing. Somebody asked whether or not stem cells are being used to regenerate joint materials, whether cadaver bone is being used in replacing knees, hips, or anything else, and whether there's been any studies with 3D printing in terms of producing some of these things out of plastic rather than out of metal. Are you aware of any research being done on that? Any of them?
People are working on it, but the short answer is no. There's no definitive use in today's medical world to use stem cells to treat arthritis. Partially because the technology is not there yet. I do believe that in the future, I think with the advent, I'm not talking about next year, I'm not talking about 2 years, but sometime down in the future, I think that technology is on its way, and I can't tell you when it's going to be. Realistically, I tell my patients probably not. I wouldn't hold your breath waiting for it. We do use a cadaver bone in certain instances in very young people where a knee replacement, because if you look, on average, a knee replacement, let's say, lasts anywhere between 10, 15, 20 years. I say average 15 years. If you're 60 years old, 15 years puts you up to 75 on average. So maybe you need one revision, so it puts you up to 90. So by then, maybe your activity level won't require you to need another one. But if you're 30 or 40 and you have a really bad cartilage problem, you know, a knee replacement is definitely not going to be your first option, right? Because if you do the math, if you keep doing these replacements, you know, it becomes harder and harder. So if you have focal cartilage lesions, there are ways where we can take the cartilage from a cadaver and actually put it into your knee. But again, it's extensive surgery, extensive rehab, but that is possible. And what was it?
Stem cells, cadaver bone, and 3D printing.
Again, I think 3D printing can be, I think, again, it's the wave of the future. There's nothing in medicine now that requires, that can be, requires the use of 3D printing.
What is 3D printing? Sorry.
3D printing is, it's like a printer where you attach to a computer where you can print out a piece of paper. Now they have the technology of printing objects and not, you know, on a piece of paper. So let's say I wanted a chess piece. Let's say I have a chessboard. It's missing a piece. I can go to a computer, you know, put in the data for that chess piece, and they can actually print out that piece for you.
Plastic, not paper.
Yeah. So I think that's something that is a couple of companies are working on it. It's not so much it will improve, you know, in terms of the way we do things in the future. I think the initial wave of what they're trying to improve is probably cost, because a lot of these implants are very costly. And 3D printing is a way that can bring down the cost. One of the ways I do to do my total knee replacements is I send patients to get an MRI, not because I don't know what's going on, but I send them to look at their anatomy, and I send it to the company to make me a block of their knee. So during surgery, I actually use that block to help guide me to see how to make my bone cuts to make it a little more accurate. And that block that they use and they make for me is from 3D printing. So that's how it kind of helps as an adjuvant to the surgery, but not directly for the surgery. So.
Thank you. We have some great questions, and please bear with us as we do them. I actually have never seen such good questions at any of these sessions, and I congratulate everybody here on their questions. I think Norman wanted to ask his own question about glucosamine and chondroitin. If you may, at this point, this is going to be a little controversial.
Somebody asked,
Well, before I want to preface this by a little story. When chondroitin and glucosamine became available about 25 years ago, I got 2 calls the same day, one from my sister and one from my sister-in-law, both asking me whether this stuff was any good for helping their knee problems. And I said, I don't know, it's relatively new, you can try it, it's not going to hurt you. My sister-in-law, who's younger than my sister, has been taking this stuff ever since then and has had very little knee pain. My sister had total knee replacements 6 months later and has done very well with those. There's your answer. But go ahead, ask your question. Go ahead.
The question was, somebody asked previously if glucosamine chondroitin is worth taking, and your reply was basically talking about the quality of the glucosamine chondroitin, not if a person would actually get real glucosamine chondroitin and take that. So my question is, if you're actually taking glucosamine chondroitin, which is actually glucosamine chondroitin and not some fake product, does it work?
Well, I'm sorry if I misled you in that regard. The point of my response to that was to say that the glucosamine and chondroitin is not a medication, right? You go to CVS, you ask for a bottle of antibiotics. It's made by a company that's FDA approved. There's a strict guideline that kind of ensures that every pill that's made of that antibiotic follows these strict criteria. Glucosamine and chondroitin is not. It's a supplement, right? One of the things that worries me is the medicine, you want things that are reproducible, right? You want to take medication that you know every time you take it, it produces this effect. And part of being a supplement, you don't have that reproducibility. That's one issue. So your question is, if you take the glucosamine chondroitin, let's say you take the right amount, the right quality, does it work?
In other words, if it says 200 milligrams
Correct.
on the bottle per capsule,
Correct.
That's what
So the short answer to that is, there's no science behind it, right? Glucosamine chondroitin is actually very important molecules in the knee that are, deficient in arthritis. So the thinking is, if you take it, if your knee's missing it, it should help. It's true if the material that you take gets into your knee, right? So if you ever look at how food is processed, you take it through your mouth, goes into your esophagus, goes into your belly, goes into your intestines. It has to get absorbed into your body, and not just into your bloodstream, it has to be actually into your knee joint itself. So the reason why I am skeptical is because, let's say you take X amount by pill into your mouth, how much of that actually gets into your knee for it to be effective, right? That is something that no one can answer, and I would venture to guess that's probably a very low percentage. That's why there are certain things that we inject into the knee, like hyaluronic acid, which is that lubrication medicine that I said. That I know, again, is something that is sufficient, but that gets injected directly into the knee where it can be useful. How that's useful, that's a completely different talk. It actually is not meant to supplement, it's not meant to add, it's actually meant to be a cascade to promote other things, but that's a completely different talk about that.
You mentioned hyaluronic being used
Correct,
as for the knee.
correct.
What about the hip?
It's off-label for the hip, but I do use it. And off-label just means a company they don't, yeah, it hasn't been tested in the hip. But if you think about it, if it works for the knee, I extrapolate it and I tell people that I use it off-label and they have to be aware of it, but I do recommend it. I
I
do.
use it as an injection.
Yep, absolutely. I use it in the shoulder, I use it in the hip, I haven't used it much in the elbow. I do use it occasionally in the ankle, but it can help.
How well does it work?
It varies. Some people come in every year and they swear by it and it tells them that I'm here for my yearly injection. Some people get it once or twice and they don't really complain of much. Some people it doesn't work at all. I tell people that you gotta try it and see.
Has any research been done why there's such a variation in effect on some people and some it doesn't?
I think it's partially because it's hard to standardize the patient population in terms of the severity of the disease, number one, right? It's hard to, if you're gonna do a study to see whether this medicine helps, you gotta have the same type of patient, with the same treatment.
Meaning what their activity is.
Correct. And also the severity of the disease. There's some people that have very mild arthritis, some people have very severe arthritis. The second reason is, I call it a gel injection, but that's not how it usually works. I think it's an easy way for me to explain it. The real way it works, it actually, once I inject the gel, it actually leaves your body in a short amount of time, in a couple of weeks. So that material that I inject is not what's meant to make you feel better. The people get months of relief, but if we look into the knee, the gel is gone in a couple of weeks. So how does it work? It's meant to work by stimulating your body's response to get more. So that's part of the reason why it may be effective for some people and not others.
Okay, this was to Dannick, a generic question. Where can a person go to get a good physiotherapy assessment?
Margaret Teets. We do inpatient, so we can't really take the outpatient. We're actually looking to get a license for outpatient, but currently we wouldn't be able to take you. It's hard for me to give you a place or the other. What I'm going to say is this. Most physical therapists that have what they call the outpatient clinics, where you can walk in and get an assessment, I've rarely heard of bad ones. Most of them are very good therapists. Physical therapy now is a doctorate, so most of them have advanced schooling. They set up their own business. They take the time to do that. They spend the money to do that. So most of them are very good. I've very, very rarely heard of bad physical therapists. If you want a little more kind of push behind it, there's New York Hospital Queens has their outpatient clinic. I think it's on Union Turnpike. where you have the physical therapists, you have the doctors, you have a whole bunch of things together. So to go to outpatient clinics that are affiliated with hospitals is never a bad thing because you get the whole hospital behind it. But most physical therapists that have an office that I've seen, all can do a very good job.
I'm going to put in a plug-in for something else over here, if I may. There is such an animal called a physiatrist. A physiatrist is a doctor of physical medicine who can assess your needs as to what kind of physical therapy you might or might not benefit from one. There happens to be one sitting in this audience right now. If you want more information about it, let me know and I will tell you about it. Okay, somebody asked about intravenous ozone treatments. I am not prepared to answer that. Anything you guys know?
Never heard of it.
Okay, that's what I know. I never heard of it. There's another question though, that it's something that's talked about. Have any studies been done on nightshades eating? Nightshades, for those of you who don't know, tomatoes, potatoes, peppers, and so on. Have any studies been done on nightshades eating and its effects? Now, that's a rheumatologist's question to answer, and we're going to have rheumatologists here, I think in April, 2 of them, and they could try to answer that. I am not aware of any scientific studies or specific ones that have been done to study them, although I will say that when I was maybe 10 years old, a few years ago, my mother went to a rheumatologist, a big arthritis doctor at Mount Sinai, and told her not to eat nightshades and her arthritis would get better. And she never touched a tomato or whatever until she passed away at 95. She had some arthritis, but probably not as much as other people at 95. But scientific studies, I can't answer that. Okay, are these parts ever rejected by the body?
Yeah. So that's a great question. Everyone asks, what is this made of? So the white plastic part of the knees is made of something called polyethylene. It's made out of hydrocarbons. We've never seen any sort of allergy or rejection from that. The metal components of the knee are made of cobalt, chrome, molybdenum alloy. That does have nickel in it. Some people have nickel allergies. I always ask all my patients, can you tolerate wearing costume jewelry, wearing 10K plated jewelry, etc. And oftentimes some women will say, I can't, it makes my skin itch, my ears turn green, or I can only wear, the good stuff. So if they answer that, then we do have implants that do not have nickel in them. So in patients who have nickel allergies, yes, you can have a metal allergy. Yes, question in the back?
You mentioned you use polyethylene as the plastic material.
Yes.
I've had some experience with polyurethane. Are they using polyurethane also as a material? And if not, why not?
No, they're not using polyurethane, and we actually have over 40 years of experience using polyethylene in terms of, and we're now in our 3rd generation of polyethylene. So going back to one of the questions was said, if I got my knees done in 05, now if I get them done again, is the technology better? It is better, and it's because the plastic is better. We found better ways to make polyethylene.
My experience with polyurethane is it's just about indestructible. That's why I bring it up.
Tony?
There are many properties that you need to look at besides the durability of the plastic, right? It needs to be, you need to be able to maintain its shape. You need to be able to, let's say, maintain the smoothness so it wears down less. So it's not just the strength. I'm sure, as you know, I'm not very familiar with polyurethane other than the coating on, outside.
They use it they make eyeglass lenses out of it also. And it's stronger than the carbonate. Can't scratch it.
Again, I've never heard of people considering using polyurethane. I can't tell you why it's the case, but I can tell you that there are many factors that they look into. I'm sure polyurethane may be stronger, but there must be another reason why it's not ideal.
Right, so like Dr. Quach was saying, there's the mechanical properties of the actual material, then there's also the wear properties. So this is a fatigue strength that goes into it. This is something that not only has to last and not break, but it has to last and not break over thousands and thousands of cycles of bending and straightening your knee out. And we've just found that, you know, I can't speak on the basic science at length about it, but I know, you know, several physicians and scientists have found that this is the material that works, is the plastic. So again, we also have a metal allergy testing that can be done in our office if somebody does have a metal allergy. So to answer the question, yes, there can be some rejection. It's mainly due to nickel, and it can be found out either by asking the patient or by a blood test prior to surgery.
You want to answer a question about shoulder replacements? You want?
Sure, I can answer.
Shoulder replacement, where does the post go, into the bone or alongside it? And two, what attaches the resurfacing plastic button to the bone?
So, in shoulder replacement, the actual ball part of it, if you have there's two types of shoulder replacement. There's a regular type, and there's something called the reverse shoulder replacement. If it's a regular type, the ball part goes into the bone itself. And it can be press fitted, meaning the component can be wedged into the bone so that it stays there and the bone grows into the implant, or it can be cemented. The plastic part is always cemented. So they put cement.
So what keeps the cement from wearing down?
That's a good question.
Cement outside on the street wearing down.
Absolutely. So that's a concern. So that's a concern for knee replacements, it's a concern for hip replacements, as well as a concern for shoulder replacements. So one of the failures of shoulder replacement is if you have like the shoulder itself, if the shoulder joint is rocking, and then so if you put cement in something and you leave it alone, chances are it'll probably wear down much less than if you kept trying to loosen it. Right? So let's say I cemented, you know, something to this table and I left it there. It may wear down in X number of years. But if I took something that I cemented to this table and I kept trying to rock it and move it and tried to break it apart, the cement's going to last much less, right?
So the point of having replacement is not just to get rid of the pain, it's also to improve mobility.
Correct.
So if you're going to beat eggs or go swimming or blow dry your hair, you're using that joint and the cemented part that's in the glenoid is going back and forth and back and forth.
Well,
so it's almost, is it saying like, you know, the less you do, the longer it will last? But that's not the point.
That's not what
Surgery.
Yes and no, but that wasn't the point I was going at in terms of that question. A normal joint, we look at the joint mechanics, the biomechanics of how the joint's supposed to function and move. If the joint's put in correctly, it should provide the minimum amount of stress on the interface between the implant and the bone, right? If you look at the knee replacement, they look at the curvature of the actual bone, the curvature of the actual implant, and this has been studied through the last 20, 30, 40, 50 years. And each generation that comes out, we improve on it because we try to match that. Match the native biomechanics, correct. The point I was trying to bring apart for the shoulder replacement is, if for whatever reason you have an abnormal kind of stress on it, then it will wear away much faster, which is why there's something called a reverse shoulder replacement. So if you had like a bad rotator cuff or a rotator cuff tear, and if you did a normal shoulder replacement in that person, then there's abnormal motion, and there is something called a rocking horse effect. So you keep rocking on that glenoid, and it will last much less.
Do they do neck replacements also? Or?
Neck?
Yeah.
They do have joint facet replacements and disc replacements, but I can tell you that's farthest from my expertise.
That's neurosurgical.
But you can't. There absolutely are. Again, they're up and coming.
Are you giving me a hint?
Well, the doctor told me I had some arthritis in my neck, he told me.
Yeah, but like I said, not just because you have arthritis doesn't mean you need a joint replacement.
Oh, okay.
So,
Now, I basically the same question from two different people, which is amazing. So I'll read them both. Is the result of arthroscopic surgery, for example, for a torn meniscus, and does that give you an increased incidence of arthritis over the next years? Another question, corollary. Do you believe that a knee arthroscopy / meniscectomy accelerates the arthritic process and makes it more likely that the person will require TKR later on?
Wait, who's gonna take this now?
He's got the
All right.
right knee, he's got the left knee.
Yeah, so that's a great question, two great questions. Does a knee scope in and of itself cause arthritis? And I think the answer to that is no. If you have a tear in the meniscus and it's repaired or trimmed back, doesn't necessarily cause more arthritis. However, most people, when they tear their meniscus, they also damage their cartilage, and that's irreversible for the most part. Unless if you have some other kind of procedure, that cartilage damage is going to stay with you throughout. Additionally, anytime that you're putting instruments in and out of the joint, there's chances that the cartilage can get further damaged just by the procedure itself. Tony, anything to add?
That's probably one of the more common questions I get before and after knee arthroscopies. So the way I answer this question is, if I took a normal knee, fully functional knee, with a normal meniscus, normal cartilage, and I took away that cartilage, took away that meniscus, then the answer is yes. By me taking away that meniscus, you probably will increase the risk of having arthritis. And the reason is because the meniscus functions like a shock absorber, right? And if you ever look at the anatomy of the meniscus, it kind of looks like a trampoline. You jump on a trampoline, it absorbs your shock, bounces you back up, right? But people who need arthroscopies don't have normal menisci. You have to understand, their menisci are torn already. And once it's torn, it's no longer functioning like a normal meniscus. So it's no longer providing the shock absorbing properties that it's supposed to. So if you had a meniscus that was injured and torn in a specific way, by me taking it out, it doesn't necessarily increase your risk for having arthritis in the future, right? Because that meniscus wasn't working the way it's supposed to. And it was only irritating your knee, which is why you wanted taking it out, all right? But you're right in a sense that the more menisci we take away, probably the more likely is it may accelerate the risk of having arthritis in the future. That's something that we speculate, but no one has ever proven, because it's a very hard question to prove. But we tell people that, and I tell patients that can happen. But you have to distinguish the fact that it's not because of the surgery that is increasing your risk, it's because you already injured your meniscus. Do people understand the difference?
I have one more here, and anybody else wants to add one. This is something, we didn't get into hip specifically, but there are two approaches to hip surgery, hip replacement surgery. The typical approach from the back, and something called the anterior approach. And somebody asked to comment on the THR via anterior approach. Take that. That's probably yours.
Right, so there's hip replacement, there's several different ways to get to the hip. There's the traditional posterior approach, which is through the back. There's also an approach called a direct anterior approach, which has gotten a lot of press lately as muscle sparing, minimally invasive, etc. There's also approaches from called a lateral approach from the side. There's an anterior lateral approach from the front to the side. And these are all just different ways to get to the portion of the body that you need to work on, prepare the bone, put your implants in, and sew them back up. They each have their advantages and disadvantages. Not one is better than the other. In terms of the anterior approach, yes, again, you have a different set of precautions. You guys remember Dannick mentioning precautions after hip replacement surgery. He showed you guys the reacher and the sock, sock aid, right? Thank you. So it's just, if you go in through the front, then you can dislocate out the front. If you go in through the back, you can dislocate out the back. Again, it's just a different way to get to the hip, and I always recommend patients to pick your surgeon and let your surgeon do what he does best. And if you have a good relationship with your surgeon and you feel comfortable with your surgeon, then there really is no difference amongst the approaches, and we have done some studies which reflect that the approach doesn't matter. They each have their advantages and disadvantages.
Thank you for that one. I have one more here, and again, if you have any more questions, please raise your hands now. Hand and wrist fusion surgery. Is it relatively new and very successful today?
Hand and wrist.
Hand and wrist fusion surgery, it says here.
It's definitely not new. In terms of fusion anything surgery, for knee replacements, in the past, before knee replacements, if you had a knee problem, an easy solution was to fuse it, right? You fuse it, you take away the pain. But like you were saying, surgery is not always about pain relief, but restoration of function. So it depends on what your goals are. I mean, if the wrist and hand fusion is possible, but the whole point of doing it is to alleviate the pain from whatever the associated cause, whether it's arthritis, fracture-related, infection-related. So, it's not new. It's been around for a long, long time. It does help in terms of relieving the pain associated with it, but you have to understand that once the bone is fused, it doesn't move. So you have to live with whatever your wrist, how your wrist is fused. Is there a part two?
No?
Have a question?
Yeah,
Yep.
go ahead.
PRP therapy, and does it build cartilage?
No.
So what does it do?